Dear Chairman, thank you for the invitation to present at the EBC 2020 meeting. The title of my presentation is Provisional Cullotte Stenting, Pitfalls and Solutions. Let me illustrate first with a case that I did now a number of years ago, a complex dominant circumflex bifurcation in a gentleman in his 70s who presented with an acute coronary syndrome, which we elected to treat with provisional stenting of the main vessel. But it soon became apparent that the large side branch would require treatment as well. I don't want to focus too much on this. The side branch after crossing pre-dilating was stented. And then what I would like to focus on is the high pressure inflation across those struts back into the main vessel to completely open the struts into the main, and then a low pressure final kissing balloon inflation, ending up with a very nice result. So indeed, we know that clinical results can be achieved that are excellent, as evidenced by Miroslav Ferencz's study in the BPK2, in which 300 patients were randomized to provisional Cullotte versus provisional TAP stenting. And as you can see from the clinical results at 1 year, target lesion failure occurred in just 6.7% of patients randomized to the Cullotte stenting procedure. Well, there are potential pitfalls, of course. We may have the ability to rewire the vessel at the time of the decision to proceed to two-stent strategy, or to advance a balloon or a stent, or we may end up with a poor opening into the side branch ostium, and there are reasons for that. And finally, there could, in fact, be proximal vessel malopposition if we're not careful about our choice of technique, in too much of a size mismatch between the proximal main vessel and the side branch we want to treat provisionally. So the inability to recross with a balloon is illustrated by this case report by Demaria, Carbanda, and Banning a few years ago, in which an 80-year-old gentleman with an acute coronary syndrome and very heavily calcified bifurcation was treated with rotational atherectomy and Cullotte procedure, but inability in the end to actually recross with the balloon and achieve an optimal result, in spite of proximal optimization with a 4.5 millimeter balloon. But we see here that this is indeed not a 4.5 millimeter diameter, this being 3.5 in the proximal LAD. So the patient returned 2 weeks later with another acute coronary syndrome, and the ostium of the circumflex was felt to be the culprit here. They rewired again, this time with a rotor wire, and rotablated, ablated the metal into the ostium, and achieved a very acceptable result at the end. So we do need to remember that the main vessel diameter should be, if we're not using imaging, 0.678 times the combined diameters of the daughter vessels, according to Finay's formula in an elegant study that was published back in 2007. So inability to rewire could be related to inadequate lesion preparation. For this, we need to do proximal optimization technique till we're blue in the face if you wish. And again, we want to achieve this diameter if we don't have intravascular imaging. Position of the pod balloon is also very important. So you have to know the characteristics of your balloon and how it relates to position. So here is a non-compliant balloon with a relatively short shoulder and a marker that's just at the proximal edge of the shoulder. Here we have a balloon that also has a similar shoulder, but a marker that's quite proximal to this. So you have to know this to achieve the best results and make sure you don't compromise, for example, the ostium of the side branch when you're ballooning with the pod technique. So this is an optimal position. I would say that gives us the best opening into the side branch and best ability to rewire, and as well as to deploy balloons and stents. So if you go at an angle like this, you may have difficulty. However, if you've optimized the angle of that ostium with a pod balloon with a shoulder in this position, you will in fact make this much easier to rewire and to pass other equipment, balloons and stents. Finally, we could have, again, problems with lack of preparation. This may require cutting balloon even at this stage, or lithotripsy or rotablation through in the proximal portion and into the side branch. We could end up with a bulky neocarina, so very poor opening into the side branch. This is usually related to where we wire the vessel, either at the proximal or at the initial stage when we're rewiring. For the provisional approach, if we rewire too proximally, we'll end up with a bulky neocarina, and we'll further exacerbate this when we're in fact wiring the second time around. So here is a very proximal rewiring. If we inflate our balloon here, we'll end up with more bulk in the carina. However, if we wire here, we end up with a very nice result in the ostia of both the side branch and the distal main vessel. The balloon position during the final pot inflation was also very important. So this was a nice model study done by Andreasen and colleagues, John Ormiston's group with Niels Holm, in which they showed that if you had a pot with a balloon across the carina, whether you had distal wiring or proximal wiring, that you had much worse opening into the side branch ostium than if your final pot was more proximal. So across the carina, very poor result, and proximal pot with much better, no restriction in the lumen. So we'll demonstrate that here. If we in fact shift this balloon to here, we end up with this result. This is a nicer opening, much better opening with a proximal pot position than across the carina, up to 70% reduction in the diameter or in the opening of the vessel. Finally, we can have proximal vessel malapposition. Is there in fact a size mismatch? Should we ever consider, if we need to do provisional stenting technique here, should we ever consider culotte here? I would say no. This is at most a 2.5 millimeter diameter vessel, and by IVUS we found this proximal circumflex to be 4 millimeters. So culotte would not be the right strategy, right technique for this particular. So in this regard, you also have to know the characteristics of your stents. These are the various stents from publication from Eng in 2016 and what their maximal cross-sectional diameter area is. This is a 2.75 synergy, for example. You can only take this to 3.6. Resolute onyx, for example, here, 2.5 millimeter resolute onyx can go to 3.3 millimeters. So in the case of our vessel, really the culotte would not be the appropriate strategy. So to summarize, culotte is a very reasonable, good bailout two-stent strategy when a single stent provisional strategy has failed. You need to prepare the lesion well, the side branch ostium, the proximal vessel, both of these need to be optimized. This may require plaque modification. And finally, we need to end well with a double kiss and a well-placed pot. Thank you very much for your attention.